Greetings, everyone. My name is Marina Spilko, coming to you from Cleveland, Ohio, and this next talk is on thoracic ultrasound. Here's you, all true superheroes, battling death and disease on a daily basis. It is my goal to show you how your ultrasound can be one of the supreme weapons in your arsenal. Think of it as Excalibur for King Arthur, or the lightsaber for Luke Skywalker, or the hammer for Thor. Let me show you how to use this as your weapon of mass resuscitation. Since multiple foes, such as pneumonia, CHF, PE, ARDS, pneumothorax, COPD, are going to wear dyspnea as their disguise, we will discuss these common pathologies that can all present a shortness of breath. The ultrasound will help uncover the etiology of this common symptom as well as guide management. The shotgun approach to treatment may not be the best course of action and may even end up hurting some folks. For example, IV fluid might be the right answer to a patient presenting with sepsis and pneumonia, but it is not optimal for patients that are short of breath and hypotensive, say from a massive PE or cardiogenic shock. Now, some of you might be asking, why do I need a lung ultrasound? Can't I just get a chest x-ray? Well, there's the radiation and cost, which especially for patients who are going to be in the ICU and are going to get x-rays daily can really add up. More importantly, many studies have shown that the sensitivity and specificity, the accuracy, or correctly identifying the patient's pathology is far better with ultrasound as compared to chest x-ray. There's also a significant time difference. For chest x-ray, an average will take approximately 10 minutes to perform versus the ultrasound at 1 to 2. This is going to be especially pertinent for time-sensitive diagnoses such as ET2 placement and tension pneumothorax. You should like to see these as soon as possible. There's also no, quote, clinical lag with ultrasound. You're able to assess if your interventions are helping in real time. For example, when you're diuresing your CHF patients, recruiting alveoli with ARDS patients, or even when you're trying to see if your patient has an infiltrate on the chest x-ray, no need to fluid resuscitate them before that infiltrate will show up. Let's talk about technique. I believe that simplicity is key. If it's not quick and easy, it'll be that much harder to perform at 3 o'clock in the morning. I have found the thoracic ultrasound to be among the simplest ultrasound modalities to master and yields much reward for the effort. As evidenced, by the way, by my 5-year-old learning to scan while he was practicing on his sister. These are the pathologic processes we'll go through today. Pneumothorax, pulmonary edema, pulmonary effusions, pneumonia, ARDS, endotracheal tube conformations, PE, and COPD, with a caveat on PE and COPD. Let's start with the probe selection. Could really use any probe you like here. Personally, I prefer the curvilinear. The main reason is that it allows for the widest view of the chest wall, allowing you to see as much of the parenchyma as possible. Also, if you're doing the fast exam, there's no need to switch probes. You could just slide up. In the vast majority of patients, the curvilinear probe is also going to be enough to see the pleural line. So approaching the patient, you hold the transducer sagittally or vertically with the indicator pointing up towards the patient's head. You place the probe on the anterior chest while the patient's supine, starting at the second intercostal space on both sides of the sternum, and then move laterally. This is the normal image you'll be looking for. This is going to be the view between 2 rib spaces. Identify the ribs by their hyperechoic line with posterior shadowing. In between them is a horizontal hyperechoic line known as the pleural line. This is the parietal and visceral pleural stuck together. During inspiration, the 2 pleural will slide and a blinking, twinkling effect will be produced, ruling out a pneumothorax. More on lung sliding a little bit later. But please note the healthy appearance of the pleural line is bright, thin, and uniform. Contrast this with this pleural line. It is thicker and more jagged-like in appearance. This can signify multiple pathology. We also need to evaluate for any hypodensity underneath the pleural line. Now returning to our normal image, let's examine the parenchyma. What you'll see are these hyperechoic horizontal lines that are equidistant from the pleural line. These are A lines, which are reverberation artifacts and signifying aerated lung. A, aerated. This does not necessarily mean that they are disease-free lungs. For instance, COPD and PE patients may also exhibit A lines. It just means that there is no density or consolidation. As opposed to this lung parenchyma where you would see B lines. The B lines are erasing the A lines. Now this represents pulmonary edema or density in the lungs. So what these are is that they originate from the pleural line and then extend all the way to the bottom of the screen. They move with respiration and therefore rule out a pneumothorax. If B lines are seen focally, it may represent a contusion, especially in the setting of trauma or pneumonia. Would also have focal B lines. So that's anterior. How about laterally? To examine the lungs laterally, we place the transducer in the mid-axillary line, indicator towards the head. I usually teach that it's just above where you would scan for the FAST exam. And if the rib spaces are the landmarks anteriorly, laterally you want to identify the diaphragm right here. Diaphragm will appear bright or hyperechoic, superior to the liver or the spleen on the left. Superior to the diaphragm is where you're going to examine the lung. Normally, aerated lung won't penetrate sound waves well, and it will appear that the parenchyma is hazy and even similar echogenicity to the liver. Further, it will look as if the vertebra or the spine end where they meet the diaphragm. In contrast, when you have fluid or density in the lung, this will conduct the sound waves and it will appear either anechoic or you will see consolidations. Furthermore, due to better sound wave penetration, you could see the vertebral bodies continuing on past the diaphragm. This is known as the spine sign. Let's try a case. True story. 20-year-old with dyspnea. He tells you that his shortness of breath feels exactly as his last pneumothorax, and he's looking to perform a self-needle decompression. Here are his vitals. He's normotensive, tachycardic, tachypnic, and mildly hypoxic. Let's take a look once again at this pleural line. You see that you could have this back and forth shimmering movement, sometimes called ants marching. If you have that, that signifies lung sliding and no pneumothorax. Also, as previously mentioned, if you have B lines, that also rules out a pneumothorax. As opposed to this clip, there's no shimmering or lung sliding. Now, when you have a suspicion for pneumothorax, it is important to identify what we call the lung point. What is the lung point and why is it important? Well, you may have decreased lung sliding for reasons other than a pneumothorax. The lung and pleural may be adherent to each other due to other pathology. In a young, healthy patient with a trauma or someone who had lung sliding, that had a central line placed and now there's no lung sliding, well, there you could be sure that's it from a pneumothorax. But in a patient that you're not sure of the etiology of their decreased lung sliding just based on history, you would want to look for a lung point. This is where the lung reattaches, and this confirms a pneumothorax. So on the screen, you see that this does not have any lung sliding until the lung reconnects, and now you have lung sliding. How do you do this? So if you place your transducer on the anterior chest wall, and like right here, you don't see any lung sliding, you simply move your probe laterally and see where the lung reattaches again. The lung point, by the way, is also a good way to track to see if your pneumothorax has increased in size. The farther laterally you move in the chest, the bigger it is getting. If you're uncertain about whether you see the lung sliding or not, you can use the M mode to help you. M mode is motion over time. Simply throw the spike down through the pleural line. Ultrasound beam is scattered by lung that is moving and sliding and will give a grainy or sandy appearance. This is known as the seashore sign. In contrast, when you do not have lung sliding, the waves are not scattered and you have a flat line top to bottom due to lack of movement, and this is known as the barcode sign. So to recap, pneumothorax. If you see lung sliding, you do not have a pneumothorax. If you do not see lung sliding, you're going to need to look for a lung point to confirm. Your M mode might help you here. Case 2, Mr. Smith. We have all seen Mr. Smith. We'll probably see him on your next shift. He has Afib, diabetes, hypertension, hyperlipidemia. He's brought in via EMS with shortness of breath and sudden onset. His vitals, he is hypertensive, tachycardic, tachypnic, and hypoxic. So you're suspecting that this gentleman is having respiratory stress from fluid overload. How do you assess for that? Well, you will look for B-lines. B-lines are the vertical artifacts that move with respiration from the pleural space. An increase in B-lines correlates with a degree of pulmonary edema. Similarly, you can assess for therapeutic intervention and seeing if the B-lines are decreasing when you're giving diuretics. With CHF and elevated pulmonary vascular pressure, you can find fluid collecting in the layers of the pleura, outside the lungs as well. This results in pleural effusions. The simple fluid, or transudative, commonly found with CHF, appears anechoic. This is also another good example of the spine sign. The sound waves are being transmitted, and you can see the spine, the vertebral bodies moving past the diaphragm. Next case, Mr. Jameson, history of hepatocellular carcinoma, and he's presenting with shortness of breath. He's borderline hypotensive, he's a little bit tachycardic, his respiratory rate is up, his afebrile, and his hypoxic. So a couple differentials here, and you use your ultrasound and you see this. Ultrasound can differentiate simple from complex effusions. The simple effusions you saw in the previous slide being all anechoic, and these are complex effusions which will have exudates, loculations, and septations. You're able to see more clearly any echogenic debris in the effusion. The etiology could be malignancy, inflammatory, or infectious. Here is another example in highlighting the echogenic material within the fluid. This could also be seen with blood products. So for pulmonary edema and effusions, anteriorly you examine the lung for B-lines in the anterior chest wall. Laterally you will look for the spine sign, look for fluid outside the lungs, and you could also differentiate if it's transudative or exudative. Next case, Miss Jones, 45-year-old female brought in by a friend with shortness of breath, cough, and fever. She's hypotensive, tachycardic, tachypnic, febrile. So you're suspecting an infection. What does a pneumonia look like on ultrasound? Pneumonia will have the following characteristics. It will have some pleural line abnormalities. You could have focal B-lines, but what you would like to focus on is consolidations and air fluid bronchograms, which we'll spend the next few slides looking at that. Consolidation of lung tissue. In this clip, we see consolidation of lung in the right upper lung. This is where it's called hepatization of the lung tissue. Hepatization refers to tissue that looks like the liver and represents consolidation. Here's another clip of lung consolidation, and you also see within it these bright hyperechoic sort of squiggly lines, and these are called air bronchograms. These are alveoli filled with fluid, giving this appearance. Dynamic air bronchograms are these lines that are moving. They represent air bubbles moving through the fluid-filled tissue, and these are pathognomonic for pneumonia. So to recap, anteriorly you will look for pleural line abnormalities. It'll be thicker, more jagged in appearance. Laterally you may see some focal B-lines, usually just one side where the infiltrate is. You will be able to see the consolidation and the air bronchograms within it. Next case. So you're on sign out. Your colleague tells you, by the way, there's no ICU beds. And you are signed out an elderly patient who's intubated, he's flu A positive, and he's been in the apartment for 18 hours. The respiratory therapist and your EM resident note that the patient's O2 sat is worsening despite increased FiO2, raising your suspicion for ARDS. Acute respiratory distress syndrome. This is a diffuse inflammatory lung injury that leads to increased pulmonary vasculature permeability and loss of aerated tissue affecting gas exchange. This is an example of a chest X-ray of a patient with ARDS. The problem is sometimes it may be difficult to distinguish on X-ray whether their bilateral infiltrates are from CHF, pneumonia, or ARDS. Let's see if ultrasound can help us differentiate. The B-line pattern is different with CHF, pneumonia, and ARDS, along with some other characteristics. In pulmonary edema, the B-lines are going to be bilateral, uniformly distributed without areas of sparing, and it'll have a normal pleural line. With pneumonia, you might have just the unilateral focal B-line, and you're going to have a thickened pleural line. With ARDS, the B-lines are going to be bilateral, but there'll be areas of sparing within them. And as opposed to CHF, or as opposed to pulmonary edema, you're going to have an abnormal pleural line and decreased lung sliding. This is an example of non-homogeneously spaced B-lines. The area here is spared. This is an area of normal lung tissue. The other nice thing about ultrasound is that research has demonstrated that you could actually see lung recruitment with your elevation and PEEP, and you have disappearing of B-lines. This comparison pic between cardiogenic edema and ARDS, and you can see that in pulmonary edema you'll have a nice thin bright pleural line and a more jagged pleural line with ARDS. They're going to be more homogeneously spaced B-lines. You'll have normal lung sliding, and if you look at effusions on these two entities, you'll in CHF be likely transudative and ARDS may be exudative. This is a recap in a chart form if that helps you to look at it this way. Next case. This is a 36-year-old female. She's 3 weeks postpartum, and she presents with swollen calf and shortness of breath. She's hypertensive, tachycardic, tachypneic, afebrile, and hypoxic. So unfortunately, you can't rule in or out definitively a PE on ultrasound, but you may get some clues. You can see some findings and abnormalities that may be able to help you out. You can see a pleural effusion on that side. The mechanism for the pleural effusion is increased interstitial fluid in the lungs, resulting from the ischemia and release of vasoactive cytokines, causing fluid to come out of the lung. You'll also see the pleural hypodensity, which we're going to talk about next. And of course, you can supplement with the cardiac and DVT scans. So what are pleural hypodensities? These are hypoechoic areas of lung tissue that extend to the pleura. They are hypoechoic because of infarction. These lesions commonly present as wedge-shaped, as seen here, but they could also be circular or polygonal. They vary significantly in size from 5 millimeters to several centimeters. This is a clip of the disruption of the pleural line by a hypoechoic density. One more showing the hypodensity with a curvilinear probe. Pure COPD or asthma on ultrasound has a normal sonographic appearance. The lungs are aerated without densities, and therefore you see bilateral A-lines, normal lung sliding, normal pleural line. With these patients, I use ultrasound to rule out other pathology, and if not present on my ultrasound, then I carry on with COPD management. Case 8. John Doe is a 20-year-old male who fell into Shaker Lake in middle of winter after running from the police. He's in a full cardiac arrest. After you intubate him, you'd like to confirm placement of the ET tube as quickly as possible. Okay, so we learned that in normal ventilated lung, we can visualize the movement of the visceral and parietal pleura sliding past each other. Therefore, if the ET tube is in the esophagus and the lung is not being ventilated, lung sliding will not be seen. So there were a couple of studies that looked at lung sliding to see if it can be used to determine whether the ET tube was in the right spot, specifically tracheal versus esophageal intubation, but also if it's tracheal versus right main stem. So this is the study. It had 9 cadavers, 68 intubations, and when they put esophageal and tracheal questions head-to-head, the sensitivity is 95 to 100% and specificity was 100%. With the right main stem, you lost a little bit of the sensitivity, but the specificity was still pretty good. This was another study in pediatric population in 99 patients, and the ultrasound was able to differentiate between esophageal versus trach in all of them. The CO2 detector failed about 3 patients. They had a false negative, and that is probably because in a cardiac arrest, you don't always mount enough CO2 to have the color detector change color. You need about 50 millimeters of mercury, so you can get a false negative. Also, and really important, the ultrasound took 17 seconds to detect, and a chest x-ray was 14 minutes. You can also visualize the ET tube in the trachea in real time for confirmation. The way to do this is to place a high-frequency linear probe in the transverse position over the anterior neck at the level of the sternal notch. You'll find the trachea in the middle of your image, and when the ET tube is inside of it, you'll see hyperechoic reverberation artifacts inside the trachea. Also note that there's an empty small lumen just to the right of the trachea on your screen. That is the esophagus, and it is so small and dark, and sometimes you may not even be able to visualize it. In contrast, in this image, when the ET tube is in the esophagus, you'll have the double tract sign or 2 pronounced lumen-like structures on your screen. So some take-home points. The ultrasound is going to narrow your differential diagnosis of your patients presenting with dyspnea. You evaluate the lungs anteriorly, looking at the pleural line, seeing if it's normally and thin and bright, if there's any hypodensities to it, if it's sliding appropriately, and then looking at the lung parenchyma for A lines and B lines. Then you could also evaluate the lungs laterally, and you're looking for the mirror sign. Normally, the lung tissue will have just a little bit less of heterogeneity as compared to the liver, and you will see the vertebrae stop at the diaphragm. When you have something that was able to penetrate the sound waves well, you'll see the spine sign. You'll see the spine going past the diaphragm. This is also the area where you can see effusions and consolidations. As with everything in ultrasound, the key is to practice, so let's get to it. Thank you, everybody.